Goedemiddag, welkom terug bij de conferentie Uitkomstgerichte Zorg. We gaan zo meteen beginnen met het middagwebinar van vandaag. Er was vanochtend al het een en ander op het programma. We hebben een talkshow gehad, er waren 2 rondes deelsessies. We hebben een podcast vrijgegeven rond de lunch. Nou, misschien heeft u al een aantal van die onderdelen ook gedaan of daaraan meegedaan. Misschien bent u wel voor het eerst nu ingelogd of ingetuned op de conferentie Uitkomstgerichte Zorg. Kan allebei. We gaan in ieder geval nu naar het webinar van vandaag. En het webinar heeft een vrij recht toe recht aan format, zou ik bijna willen zeggen. We hebben een hoofdgast die circa 30 minuten een presentatie geeft. Tijdens die presentatie kunt u de vragen die u heeft of die u in u voelt opkomen stellen natuurlijk. Dat kan op dezelfde manier als vanochtend. We hebben een vragenveld. Kijk even achterom of die in beeld is. We hebben in ieder geval linksboven uw scherm hier een vragenveld, een Q&A-veld. Daar kunt u weer vragen inzenden tijdens de presentatie. En wij verzamelen die met een aantal moderatoren en een aantal daarvan kunnen we dan voorleggen aan de hoofdgast. In de webinars kijken we naar eigenlijk wat er in andere landen onder andere gebeurt, wat we daarvan kunnen leren. En vandaag is dat Wales. So I will be switching to English now. And with us today is Sally Lewis. Are you there, Sally?
Yes, I'm here.
Hi there.
Hi.
Thank you for joining us.
Thank you for having me.
Sally, you are the National Clinical Director for Value-Based Healthcare at the NHS in Wales. And you will be sharing with us your approach in Wales. I told the participants you will be presenting for about 30 minutes or so. And they can send in questions and we will be addressing some of them after you have finished your presentation. Is that okay with you?
Great. Absolutely perfect.
Okay. Well, then all I have to say now is take it away, Sally.
Thank you very much. So I'll try and share my screen now. And this is the moment where we hope there's no technical hitches, of course. So here we are. Firstly, it's a pleasure to be here. I wish I was there in person in the Netherlands. It's a very favourite place of mine, but sadly, we're still very much part of the virtual world, aren't we? But arguably, this is a great time to be having this conversation because I would argue that never has it been more important to focus on outcomes in healthcare and the value that we deliver for patients and the public from our healthcare systems as we move out of the pandemic, having had a real focus on COVID-19 for the past 15 months. We really need to turn our attention to outcomes from non-COVID issues as well. So how might we look at value and outcomes focused care in the context of an integrated healthcare system? I think over the last few years, we've all been very much more focused on outcomes. And I know in the Netherlands, you have done a huge amount of work in this area and are world leaders. But outcomes alone, as we know, are not sufficient. We need to look at value. We need to look at sustainability of healthcare. So we're really trying to bring together person-centered healthcare, so shared goal setting and decision making, really trying to understand what matters to individuals, alongside how we get the biggest quantum of health gain for the population as a whole and equitable access to healthcare for the whole population. And how do we make that affordable and sustainable? And then where does value come into that? Well, of course, we need to achieve the best outcomes, the outcomes that matter to people, with the available resources that we have for people living with similar conditions or with similar sets of needs across a whole pathway. And I'll come back to that in a little bit more depth later. And of course, delivering value means that unwarranted variation, waste and harm, quality improvement, and the development of new models of care supported by digital technology are all important aspects and tools for us to achieve value across the system. So we're trying to achieve that sweet spot in the middle, really, where we get the best value, the best outcomes for the population and at an individual level. And this slide is something I've been working on with colleagues from the Netherlands, actually, with Professor Anne Stiglboot from Leiden University, and colleagues, and is the basis of a report into the implementation of person-centred and value-based healthcare, which is going to be published later this year and which may interest you. So what does it look like to have outcomes-focused and value-based healthcare at a pathway level? Well, it's very difficult for hospitals to deliver this on their own, of course, because we need to consider the needs of people living with a condition or at risk of a condition, indeed. So if we're thinking about heart failure and a pathway in heart failure, we need to be thinking right across from prevention, timely diagnosis, optimizing the intervention and management of heart failure, but also getting it right as people move forward into their advanced stages of the illness and they require a movement from a very invasive treatment perhaps to a more supportive and palliative approach and end-of-life care. So you'll see underneath the pathway there are all the interventions that we might want to optimize along that pathway, thinking about where we are best placed to deploy our resources to get the best outcomes across that pathway, and what data do we need to support that. So hospitals alone really can't do this, so we have to think about how we get value across the system of healthcare, and that of course is very, very challenging for lots of reasons. Many of us have been focusing on efficiency and productivity in healthcare systems for a long time, and that remains very important. Of course it does, but that does not equate on its own to value, and we shouldn't persuade ourselves that efficient processes, productive healthcare systems necessarily always deliver the outcomes that matter to patients and therefore delivering value for individuals and the population. And why is that? Well, despite many of us talking about outcomes that matter to patients for quite some time, the truth is that we still have huge gaps in our knowledge of the sort of outcomes that patients and the public are getting from healthcare. And so I still love this quote from Voltaire, which is that doctors pour drugs of which they know little to cure diseases of which they know less into patients of whom they know nothing. And whilst we hope that evidence-based medicine has taken us on a long way along this journey to better healthcare, it's still true, this statement, and particularly around what we understand about patients' goals and preferences and their outcomes. So what's the consequences of that? Well, we don't really understand multimorbidity effects. So randomized controlled trials will tell us about the efficacy of a new drug or intervention, but very often we extrapolate so much evidence to people who would have been excluded from those trials. So it's our duty, I would say, to collect outcomes from those people to understand in real life what is happening. I've mentioned we don't really understand about goals and preferences and context of patients, and therefore it's very difficult to understand what is unwarranted variation from a pathway of care as opposed to warranted variation that might be due to a patient's choice. The Holy Grail, I suppose, is to collect a lot of outcome data over time so we can start to reflect much better information back to people to support that shared decision-making process so that people can make much better decisions around the interventions they want for their context to achieve the outcomes that matter to them. And of course, we have no way of objectively knowing how people are getting on at home. And as a clinician myself, I would manage that risk and that worry by repeatedly following people up. And that might be reassuring for me, but might not be the best thing for the patient or indeed the system in terms of sustainability. So we have to create a culture around outcomes measurement, as you know, and really change our mindsets towards doing that so that outcomes data sets are seen as really essential in the delivery of any healthcare system around the world. And creating that common language and supporting audit, but turning clinical audit from something which may have been an annual report from a registry or a data silo of some type into much more real-time use of clinical audit data. Putting alongside that then patient-reported outcome data, of course, which can be generic, so generic PROMs looking at quality of life, pain, sleep, and my ability to carry out activities of daily living, but also condition-specific PROMs that look at symptom burden and can be a really useful communication between patients and their clinical teams. And we need also to look at psychosocial PROMs, including loneliness, really pertinent to people coming out of the pandemic who may have been shielding from the world for a long period of time. And to look at the burden of care, complications, and the burden of processes of care. So how much are we organising care around our needs rather than patients' needs and making it a full-time occupation for them? So what are PROMs and why may they be useful? Well, traditionally they've been used to look at cost effectiveness of interventions. They are, of course, a structured questionnaire, structured communication between patients and their clinical teams, ideally. But they have a range of uses that can be really, really helpful, including in supporting the direct care of an individual. So here's an example in heart failure again, where using a PROM with an individual shows how you can track their physical functioning over the course of their disease from diagnosis through to end of life. And you'll see at the beginning of the graph, their functioning falls down as they become symptomatic and then responds to treatment, and we get up to a plateau phase, which may last for a number of years. So you can see that we can use the PROM there to track how quickly people are responding to treatment and how good we are as healthcare systems at responding to that diagnosis and optimizing treatment as quickly as possible. And then as we get into that more palliative phase, we can identify trajectories of illness where we've been quite poor at doing that in the past, and we can identify that clinical instability and poor response to treatment. And that enables us to plan much better with patients the most appropriate care to meet their needs and achieve the outcomes that they would wish. And I'm sure you'll agree that that type of approach is a way to drive value in healthcare from everyone's perspective, from the patient in terms of meeting their needs and their wishes, but also healthcare system sustainability and clinical workflow. So the point I'm trying to make is that outcomes are more than just a result of an intervention. They are communicating a status. It's a milestone as well as an endpoint which matters to a person, and there are rich ways that we can use this information, nuances between chronic disease like heart failure and episodic care like a knee replacement or a cataract surgery, for example. And we can use them in direct care with an individual, as I've highlighted, as a symptom tracker, like the heart failure graph, to support shared decision making. What's likely to happen to someone like me if I make this decision or that decision? And as triggers for key conversations like end-of-life advanced care planning and the type of care I may wish to receive. And then when we aggregate up PROMs, we start to see analyses and benchmarking and the more traditional use of PROMs we may be familiar with, but they're also absolutely fantastic at identifying unmet need in your communities. So an invaluable data set for planning high-value services, either in a hospital setting, primary care, or wherever patients have unmet need across the pathway. So a word about evidence-based medicine, I guess. Has it succeeded? And of course, it's taken us a very long way in terms of the treatments we use and standardizing care where that's appropriate. But the original and best definition of evidence-based medicine from David Sackett here always included integrating the patient's preferences and uniqueness to their encounter. So One of the downsides of evidence-based medicine is that it has generated a lot of standardized guidelines and pathways, but they don't necessarily take into account always that patient's input. And there's a danger that we have made care overly mechanized factory line and not included that full definition from David Sackett. And it's really important that we reclaim that ground. One of the other things which drives low value care in the system is that we confuse activity with progress, I suppose, and we assume that every outpatient appointment, every referral is forwarding the needs of the patient or creating value by improving outcomes. And that's just not the case. Activity is highly sensitive to both the preferences and choices that patients make and supply. So care that's initiated or driven by the profession. And we need to be mindful of this. So from a patient's perspective, the choices they make are absolutely influenced by the availability of time and information to support that shared decision-making process. And therefore to reduce any bias the clinician draws into the conversation and really seek to meet their goals and the optimum trade-offs between benefits and risks. And of course, that needs to be invested in both the time with patients to do that process, but also investment in evidence-based alternatives where that's appropriate. And on the supply side, the more care you give, the more care you give. Tests generate more tests, referrals generate more referrals, and so on. And we just need to be mindful of that and our own behaviours in the healthcare system in consuming services so that we can describe what is optimum for a value-based healthcare system. So how might we finance for value? Well, this is really difficult. This is Elizabeth Taysberg on the right here, who wrote the value-based healthcare book with Michael Porter, as you probably know. And in the States, value-based healthcare advocates bundled payments that are rewarding outcomes that matter to patients. But it's actually very difficult to benchmark PROMs when you don't know what the original goal was of that diverse range of patients. So financing for value is probably more complicated than we have liked to admit, frankly. But there are still ways that we can incentivize excellence, perhaps by optimizing standard processes and reducing unwarranted variation. So if we think back to that heart failure graph, incentivizing the first part of that pathway so that people get optimized treatment very quickly seems like a good way to go. But equally, we need to invest where personal preferences matter. So investing in culture, in the time that we have to give patients and the information so that we can truly do shared decision-making and avoid harms of overtreatment in patients. And Elizabeth describes that as a focus on capability, comfort, and calm. And that's can't really be incentivized because it's very individual to the patient's own goals. So we need to invest in that. So one of the criticisms of patient-reported outcomes is people say, well, it's very laborious to collect these, it's hard, it's too expensive, etc. So how do we do it at scale? And the answer to that lies with digital health and enhancing digital communication with patients, as we are increasingly doing, and that has accelerated, of course, hugely across the course of the pandemic. Because once we've enhanced that electronic communication with patients as part of their direct care, we can enable a whole bunch of tasks to be completed by the patient and their clinician, empower patients to really become involved and far more active in managing their own care using some of those digital tools. And of course, that allows large-scale, semi-automated collection of patient-reported outcomes as well. And that's what will give you a sustainable PROM collection system that also gives you high response rates. And of course, the other important thing to note on the how is patients and clinicians need to be able to see that data. If that information goes into a black hole and nobody can see it, what's in it for me, you know? So data visualization and accessibility of that information for patients and clinicians alike is absolutely key to success here. And that means we need to align our digital strategy with our clinical and financial strategies, of course, and we'll come back to system level approaches to outcomes focused and value-based healthcare in a moment. But these are some of the tasks that we might start to do digitally with patients, including PROMs, to support those new and more flexible models of care that hopefully also begin to add value across the whole system, and possibly even allow patients to integrate us across the healthcare system. We've been trying to integrate healthcare and social care for a long time in the world with limited success, I would say. So maybe this is a way for patients to integrate us. So one of the things we have to do, of course, to create a more outcome-focused and value-based healthcare system is to use data to gain insights and have a much more data-driven approach to decision-making at every level of the system, from direct care through to policy decisions, I guess. So one of the approaches in Wales is to create a suite of information products for various conditions and groups of people with similar needs, so that we can start to put costing and outcome and process data together to tell a story and try and sort of shine a light on problems which can be driving poor value care or poor outcomes or both within the system, and then devise solutions to tackle that. And of course, key to that is having a regular data feed. So the problem with clinical audit in the past was that the data was just always out of date by the time you saw it again. So we're trying for a monthly data feed or so to help us with this. So just to finish off a little bit then about what this means for constructing a value-based healthcare program, including outcomes measurement across the system. So I mentioned Elizabeth Taysberg and Michael Porter earlier. Well, they say this in their book: each department or physician practice takes a piecemeal view of care. So piecemeal care is a major problem driving poor outcomes, inefficiency and low value across the system all over the world, I would say. And so we need to knit those pieces of the jigsaw together. And in the States, they talk about doing that with integrated practice units, which focus care around a group of patients with the same condition or a group of patients with similar needs. In Wales, of course, we have integrated health boards, which cover primary and secondary care. So we have a kind of virtual approach to that, if you like, where virtual teams across that whole system of care, from primary care into secondary and tertiary care, work together across the pathway to try and devise optimum care for patients, supported by the outcome data that I showed you earlier. What's the point here? Well, I think that the point is somehow we have to integrate care across a whole system pathway, but there will be different approaches and solutions to doing that depending on which healthcare system we're in. Philosophically, you remember the Venn diagram at the beginning of the presentation, where we are in our values as a healthcare system, how much we are focusing on the individual or the population, and where we are across that spectrum. But we will find our own ways, I think, to integrate healthcare in our own countries. And then the really critical thing that I've learned with my clinical hat on, I'm a general practitioner by background, is that no one discipline can solve this alone. And we need everybody in the room to start to solve some of these different problems. So we need clinicians from the multidisciplinary team, alongside financial and operational managers and informaticians to help us do this. One discipline cannot do this alone. We need to align digital strategy with clinical strategy, absolutely key in the modern age, and really challenge ourselves around our own innate bias towards the status quo. So can we do things differently towards higher value in the system? And move towards value-based decision-making that's data-driven, using some of the data approaches I mentioned earlier. And then bottom-up and top-down. So in Wales, when we were starting off on our value-based healthcare and outcomes-focused journey maybe 5 years ago, and certainly over the last 2 to 3 years, it's very important that this becomes a movement from the ground so that healthcare professionals, patients and providers believe in this and want to do it, so that it grows from the bottom up. But then at some point you do need policy to come in and take away some of the barriers to this developing and becoming a whole system approach. So you need bottom up and top down, and hopefully we meet somewhere in the middle. And certainly in Wales, where we are at a place where we were bottom up, and now we have key policy initiatives supporting the implementation of value-based healthcare across Wales. And that's really important if you're going to align digital strategy with clinical strategy, because if policy doesn't align with that, it's very difficult to do. And so finally, therefore, the National Value-Based Healthcare Programme in Wales was set up 2 years ago. And it is not there to impose a programme of work on the integrated health boards in Wales or on secondary care clinicians or general practitioners or managers or whoever. It's really that series of enablers trying to unblock obstacles to value-based healthcare delivery across the system. So how do we support patients in shared decision-making and also co-creation of services? How do we work with patients to raise their health literacy and understand how to use the information that we present to them? How do we help them navigate the system? That's goal one. Goal two, of course, has had to focus very much on building data infrastructure around outcomes and costing measurement. And we've made a lot of progress on that, still a lot to do, but that's a really key goal if we're to support value-based healthcare across the system and learn how to benchmark with each other as well. Communications, education and engagement. We, of course, need to continue to engage professionals and patients alike across the whole system into why we're doing this and why it's important, and build the ethos of this into everything from undergraduate medical curricula into executive education. And we're extremely fortunate that Welsh Government have funded an intensive learning academy for value-based healthcare in Swansea University, which has been ably led by my colleague, Professor Hamish Lane. Capacity and capability building. So we need to support change management within organisations and provide advice on how to implement patient-reported outcome measurement in direct care, for example. And then we need to work with industry partners to understand what this means perhaps for outcomes-based agreement and how we optimise the use of drugs and devices across the pathway for the highest value. And research into value-based healthcare, which could be anything from how do we benchmark to how do we finance for value, or how do we present a data visualization of a patient-reported outcome that makes sense to a patient. And then finally, our strategic partnerships. External validation of what you're doing outside your own country is incredibly useful to keep up the momentum inside. So we really like to have friends outside of Wales, and that can be informal, but also we have some strategic partnerships now with the OECD, partnering in their Paris programme, looking at primary care patient indicators as a suite of measures to add to global healthcare system comparators. And finally, the World Economic Forum, which has named us, I'm very pleased to say, as a global innovation hub for value-based healthcare as part of their global coalition over the next 2 years. And of course, the Netherlands are well represented by Diabeta in that partnership too. So having these 6 goals, these 6 enablers now at a policy and a healthcare delivery level helps to support the clinical teams and patients on the ground to deliver that value-based healthcare and outcomes-focused impact that we are really looking for. And that's my last slide, so I will stop sharing. But that's a quick tour of what value and outcomes-focused care means for us in Wales and how we've constructed it from the bottom up and now up into that policy layer as well. Thank you very much for listening.
Thank you very much, Sally. Great to hear from you, and it's also great that you're willing to share your approach with us. There are some questions that I would like to ask you. The first one maybe is the patient is quite an important person or role in value-based healthcare. How do you work with patient groups or patient organization? What is their position in this transition?
Yes, really good question. And the truth is that some patient organisations are further on in their thinking than others in this regard. So we have, for example, quite a close working relationship with the Crohn's and Colitis Society in the UK. They are fully supportive, I would say, of a value-based healthcare approach to care. Similarly with the British Heart Foundation. So there are sort of more formal patient organisations that we are working with. But of course, it's really important to work with patients on the ground as well, either supported through the national team or more frequently now, as this has grown, through clinical teams on the ground. And I think it's fair to say that the vast majority of the time, patients absolutely are on board with this and really get this in terms of co-creating new models of care, starting to embed digital technology across pathways, even for elderly patients, actually. But where I think we need to figure out how to do better is that bit around more time for decision making and better presented information for people to make those choices. So we have option grids around, how to make this choice or that choice, but how do we back that up with information, outcome data, so that people can understand what likely outcomes they're going to get for somebody like them. So it's work in progress, like everyone else, I guess.
Yes, you're working with that and on that, but patients are quite closely involved, patient organizations. Is that correct?
Yes, correct.
Okay, another question maybe. I was wondering, how does the National Value-Based Healthcare Programme from Wales fit with the Quality Outcome Framework for general practitioners? I can imagine that they sometimes contradict or are not always aligned. Could you say something about that? It's a question by Anne Stichelbout.
Yes, great question. Yeah, so the Quality and Outcomes Framework for General Practice, which was brought into general practice in 2003, 2004, and which I implemented in my own practice at the time, was really incentivizing bundles of care, I guess, around certain conditions. And this was one of the reasons, actually, which led me to think that that was insufficient to drive better outcomes and value, because it, and I think the hint is in the question, really. It was very standardized, so it didn't tailor care well, and it did drive some over treatment. And if I can give you an example of that, it might be in, let's say, glucose targets in elderly patients with diabetes, or blood pressure targets. And we were perhaps, for some patients, creating harm by being overly aggressive to meet the targets from the QOF, which were incentivized. So bad, even though we were able to tailor care and exception report people from that, it did definitely drive a mechanistic approach to care, I have to say. So standardization, good, but when you overdo it, you risk over treatment. So the question for me is, how do we get a balance between incentivizing standardization that raises the bar of care, whilst also really focusing on the individual's needs and not penalizing the appropriate tailoring of clinical care and that therapeutic approach, that wonderful therapeutic approach that you get between a clinician and a patient when that works well. So I don't think there's a perfect solution to this, but somehow we need to strike a balance between those two approaches, I would say.
Where do you think the key for that balance might be found?
Well, I think I can't see another way of doing this other than needing to record the goals and wishes of individual patients alongside standard measures like that. Because if we don't know what people's wishes and circumstances are, it's impossible to have a complete view of whether an outcome is good or bad.
That brings me maybe to another question. How motivated are people, patients, in filling out prompts? You said something about digital tools.
Yeah.
How do you motivate patients to use those tools or to fill out prompts?
Yeah, it's really important that is not a data collection exercise. It's got to be useful for patients as well. So people need to see that it is an essential part of their care, and that their clinician is going to use that information, and that they can also use that information and track it themselves, perhaps over time, as part of a program of supported self-management, I would say.
Yes.
So chronic, yeah.
Sorry, go on.
No, that's fine. So really important to embed it in direct care. Otherwise, why would you do it as a patient? It's got to be meaningful.
Right. Another question. What was, in your personal experience, the biggest eye-opener regarding the transition to value-based healthcare? Could you illustrate that maybe with an example? So what was your biggest eye-opener?
The biggest eye-opener?
Yeah.
The biggest eye-opener for me was the realization that I'd been a clinician for about 20 years and had never thought about how little information we have in the system that we use about the impact of our healthcare. So how little outcome data we were using to guide care. And once I, thought that, I thought, how on earth did I not think about that before? So that was, a big eye-opener for me. The other eye-opener, I think, was talking to some patients about their experience of using healthcare and how far removed their experience of it is, perhaps from our perception of their experience of it as healthcare professionals, and therefore how we need to make it better.
So this was an eye-opener for you also as a general practitioner, I guess.
Yes.
That brings
Yes,
me
absolutely.
to a couple of questions we have online, and it's about how open or willing professionals were to, show their results, compare results, work with outcomes. Could you say something about that? How motivated are clinical experts or clinical professionals in general in Wales, and how easy or hard was it to involve them in sharing outcomes and comparing outcomes?
Much easier than I expected, actually. Although the caveat to that, I would say, is that there's variation across the specialties. So in general practice in the UK, we're very, very used to comparing data and benchmarking various data sets between ourselves, even with named practices. So we've been doing that for so long, for us, that's normal. For surgical specialties, I think it's perhaps more challenging because they have worries about how data is interpreted. So I think we need to be really careful and work with healthcare professionals and take them on a journey, really, so that there is trust, that there is robust data analysis, and we are not telling a story that is incorrect, because that would be unforgivable, actually. So I think we're very careful about the insights that we draw from the data, and we have a very clear process around a clinical reference group to support the drawing of those insights from the data. Because if you have a non-expert group looking at the data, it's very easy to draw the wrong conclusions, particularly with patient-reported outcome data. So it needs to be done carefully, for sure. But if it is done carefully and in a stepwise approach, in general, the clinicians are very interested, because clinicians turn up to work to do a good job and help patients. So they want the information, generally speaking, to understand how they're doing, how they can meet needs better, and how they can improve. But it is important that it's done in a robust and trustworthy way, for sure.
So one of the questions, for example, is how did you support a learning culture, so to speak, between amongst professionals? But I think you are saying that you already have had such a culture, learning from data and outcomes. It was not a big leap for you in Wales, if I understand it correctly.
To an extent, that's true, and there's variation across specialties. So for general practice, it's normal. That's been in place for years, probably because of QOF and prescribing data and all of that. For cultures like medical specialties, looking at diabetes, heart failure, stroke, and so on, generally those guys are really comfortable with it. As I say, it's a little bit more complex with surgical specialties, but as we get better at this, I think that certainly they're absolutely on board, and they just are asking for care in how we display the data and how we explain what it means, particularly to the public who may not be as well versed in how to interpret certain of the data issues that we've come across.
So, and how do you then deal with specialties where it's a bit more difficult?
Well, carefully.
Okay.
So I think with, it's like with anything, if you go with the early adopters first, and then you have to earn the trust from the other clinical specialties. And when people can see that you're your intentions around this are for the the right reasons. You're doing this for the right reasons, and actually the data is for them, and it's to improve care. It's not a stick to beat people with. That's not why we're doing it. It's not about saying you're bad, you're good. It's about understanding the outcomes that we're getting, because let's face it, in Wales a lot of our outcomes are very poor. And they're poor for lots of reasons, not always to do with healthcare. You know, we've got high levels of rurality, deprivation, and ill health. So it's about understanding outcomes and insights and doing something about it together as a system, rather than using data as a stick to beat people with.
Okay. 2 questions to wrap up, and then I will be addressing the participants for a short while in Dutch. 2 questions. One, what do you think about the role of nurses and nurse practitioners in value-based healthcare? Could you say something about that, maybe briefly?
Yeah, they're I would say, the cornerstone of value-based healthcare delivery in Wales. All of the best case studies are led by clinical nurse specialists and nurse practitioners.
And why is that?
Well, because I think they have seen, perhaps certainly in secondary care, more than some of the consultants, the value of the PROM as a communication tool between them and the patient in order to support care in a number of ways. I don't know why that is, but it's the truth. And we've just had a new chief nursing officer appointed, who I met with the other day, and she will join us in August and is absolutely committed to having the nursing profession front and centre of value-based healthcare strategy in Wales, which is really exciting for me because it's absolutely key to the success of this.
Okay, final question. You may answer with yes or no if you like, but you can also say a little bit more, of course. I was wondering, do you have some sort of national ICT structure or infrastructure in Wales, or are you making anything along those lines?
Wow, now that could take me, there's a long answer and a short answer to that, as you can imagine. So I'm
Yes.
going to say yes, and more to do.
Right.
But maybe that's a conversation for another day.
Okay, but you are working on that.
Yes.
Okay, well, thank you. Sally, I will be addressing the Dutch participants in a minute in Dutch to finish off. But for now, thank you very much for sharing your story with us. And all the best of luck in Wales with value-based healthcare.
Thank you for having me.
Oké, ik ga nog even tegen de deelnemers het volgende zeggen. Dit was de webinar, de internationale webinar. We hebben er morgen nog een. Dan leren we vanuit Duitsland en een paar lessen. Om 7:30 straks, dus voor nu is er even geen programmaonderdeel. U kan natuurlijk de podcast nog altijd even beluisteren als u een wandelingetje maakt de komende tijd. Om 7:30 beginnen de deelsessies ontwikkelingen in de zorgpraktijk. Daar heeft u zich al voor aangemeld als u dat heeft gedaan bij het aanmelden voor de conferentie. De link zit dus in uw mailbox. U kunt daar nog even naar zoeken. De afzender van die mail is Uitkomstgerichte Zorg. Mocht u hem niet 1, 2, 3 vinden, kijk ook nog even in uw spambox. Dus die deelsessies beginnen vanavond om 7:30. En om 8:30 sluiten we af met een talkshow. En dan gaan we het hebben over het samenspel tussen patiënt, verpleegkundige en arts. Dit was de webinar. Dank voor het kijken en meedoen tot zover en tot vanavond.